Good afternoon, everyone, and welcome to our Far Away from Home ARC East Midlands webinar. My name is Kapil Sayal. I'm part of ARC East Midlands and based at the University of Nottingham, where I work as Professor of Child and Adolescent Psychiatry and also work in CAMHS as a consultant child and adolescent psychiatrist. And I'm really pleased and proud to be able to chair today's webinar, at which we'll be presenting our findings and learning from our cross-ARC collaboration. The Far Away from Home study focuses on under 18s who've been referred for a mental health admission, but are then admitted far from home. That could be either at least 50 miles away from their home or out of area to a different region. The study was led from Nottingham through ARC East Midlands, and in fact is a very unique partnership with 4 other ARCs, Applied Research Collaboration regions all across England, partnering with the East of England, Oxford and Thames Valley, Greater Manchester, and the West Midlands. And what this did was it allowed a nationally representative study, particularly our main quantitative study and qualitative interviews with healthcare professionals had an England-wide spread, and you'll be hearing about those in more detail in a minute. In addition to that, we also spoke with and interviewed young people, parents and carers, healthcare professionals and commissioners across the participating 5 ARC regions. So today we're going to hear from 3 of our leading researchers across this programme of work, each of whom will share a particular focus and lens on the work that we've carried out and the implications that arise for service providers and for commissioners, as well as, of course, for affected young people and their parents and carers. And finally, at the very end of the webinar, we are very excited to be able to launch 2 animation videos which summarise the Far Away from Home project and the findings. At the end, through a QR code, we will share the links with you, and we will also email these to you as attendees. And we'd be really grateful if you could then circulate these very widely, particularly with your colleagues and also members of your wider multidisciplinary teams. So with no further ado, I'm going to introduce our first speaker, who is Dr. Josephine Holland. Jo is a clinical assistant professor and ST6 trainee in child and adolescent psychiatry based in Nottingham. And Jo will be presenting findings from the national surveillance study that we carried out in partnership with the Royal College of Psychiatrists. So over to you, Jo. Thank you.
Thank you, Kapil. So thank you, everybody. Good afternoon. So today, as mentioned by Kapil, I'm going to be presenting part of our Far Away from Home study, and particularly with a focus on the national surveillance study, which we conducted. Next slide, please. So the Far Away from Home study represented a program of research, as Kapil has highlighted, and this diagram helps you to see where what I'm presenting helps to fit in with the other studies, some of which will be presented today. Next slide, please. So these were the key questions that we wanted to use a surveillance study to find out. As clinicians, we have experienced having young people admitted far away from home, but what we wanted to know is actually how often is this happening? Who are the young people to whom this is happening? And what are the clinical characteristics of these young people at admission? We then wanted to also follow them up to try to understand some of the journeys that these young people are going on and to be able to capture their outcomes at 6 months. Next slide, please. And in terms of what we did, so as mentioned, this was a surveillance study, and this ran from February 2021 to February 2022. And then following that, we also had a 6-month follow-up that covered all of the admissions that had happened and been reported to us during that time. We wanted to capture data from across England. So we were wanting to know about young people aged 13 to 17 who are admitted to a general adolescent unit either at more than 50 miles away from their home or out of their commissioning or NHS region, or to an adult psychiatric ward. And in order to do this, we use the child and adolescent psychiatry surveillance system, which I'll just outline a little bit more on the next slide. And for each of these young people's cases, we collected a baseline questionnaire and a follow-up questionnaire. Next slide, please. So the surveillance system, or CAPS as it is shortened to, is hosted by the Royal College of Psychiatrists. And what this system allows you to do is it sends out an email each month to every child and adolescent psychiatry consultant who is signed up to their system. And if any of you attending today are a child and adolescent psychiatry consultant who's not signed up, we would encourage you to do so. And what we found through this study was that we ended up with two ways in which cases were reported to us. So one way was through these monthly e-cards, as they get referred to, where the consultants are asked to indicate whether they've seen a relevant case to the study. But then we also found that some consultants became so familiar with the study from reporting cases that they actually would often directly report cases to the study team, even before their yellow e-card had come through for the month. Next slide, please. So what did we find? We were able to capture rich clinical information about 290 unique cases during our surveillance period. And of these, as you can see from this diagram, the vast majority of them fell into the category of being far away from home. So they were usually general adolescent unit admissions, either more than 50 miles from home or out of region, or as you can see from this diagram, frequently both. We had far fewer reports about young people admitted to adult wards, and we have some thoughts about why this might be the case. Perhaps because some of the adult inpatient consultants who would have been receiving these patients will not have received the CAPS surveillance cards and therefore may not have been triggered to report these cases. Through a lot of hard work, our 6-month follow-up rates were extremely high, with us being able to capture the 6-month follow-up information for 98% of the cases which were reported to us. Next slide, please. So we were able to use this information to then try to answer the question of how often is this actually happening here in England. So based upon our study sample, plus some additional adjustments and sensitivity analyses that we had to do, based upon the fact that only about 40% on average of consultants return their e-cards, we were able to calculate that this gave us an adjusted estimate of around 3.66 to 16.93 per 100,000 13 to 17-year-olds. And then we were very fortunate to be able to triangulate this with some of the NHS England data, which was provided to us. And actually what they showed was that their adjusted estimate was within the estimate that we had calculated, suggesting that this was the correct amount. However, when I've presented this as a figure at other conferences, people have said to me, I don't really understand what that means. So it feels like a more clinically relevant piece of information to explain that actually what we were finding was that around 25% of all general adolescent unit admissions that occurred within that period of time that we were conducting surveillance were to units which would have counted as far away from home and been eligible for the study. It was also pleasing to see that actually our study was able to capture over 50% of the admissions that would have been relevant during this period of time. Next slide, please. So thinking about who are the young people that are experiencing these admissions. So as you can see from this table, the majority of these young people are female sex, and they tend to be of the older adolescents, so are more likely to be 16 to 17-year-olds rather than 13 to 15-year-olds. When looking at the ethnicity which was recorded for these young people, as you can see, the majority again fall under a white ethnicity. However, in our study, we did find that there seemed to be an representation of Black ethnicity males within our sample. What we don't have is the accompanying ethnicity of the young people admitted close to home. So we don't know whether this is an overrepresentation amongst all young people admitted to hospital, or whether this is something that is particularly seen amongst those sent far away from home. It's also important to bear in mind that these numbers are relatively small, and therefore drawing strong conclusions is quite difficult. Next slide, please. In terms of thinking about the clinical journey that these young people have been on in the run-up to their admission. So as shown in this slide, most of them are known to CAMHS, so 4 out of 5 at least. And of those who are known to CAMHS, actually more than half of those have been known to CAMHS for more than 6 months. So these aren't young people, in majority, these aren't young people who are newly presenting to CAMHS. Actually, the sort of urgency and emergency nature of these admissions is really high. So 81% are requested as emergency admissions, and over half are detained under the Mental Health Act. When asked about other additional reasons for referral, clinicians indicated that suicide risk was present in 80% of these young people. Over half of them also struggled significantly with managing their emotions, and psychotic symptoms were present in over a fifth. Next slide, please. But in terms of diagnoses at the time of admission and then at discharge as presented here, the most commonly presenting diagnosis was depression. Young people were able to have more than one diagnosis at the time. Another concerning thing was the number of young people, or the percentage of young people within this sample who had a diagnosis of autism spectrum disorder, which, as you can see, is high. And as a disorder, we know that this may add additional complications to the aspects of being far away from home and further away from support networks. And as highlighted at the top, nearly a fifth of these young people had no diagnosis at the time of their admission. Next slide, please. As well as being able to give us tick box information, we also provided some free text boxes for the consultants to be able to sometimes type, and this is one of those areas. So what we also asked was, why were the young people sent far away from home? And the vast majority of those, again, was about there being no local bed available. And another 22% of those were actually to do with issues at the local unit. For example, the current patient mix or the availability of certain services or capabilities of the local unit, which sometimes were therefore preventing a young person from being able to be admitted there. The consultants then had the ability to type a free text response if they had additional comments they wanted to make at that point. And we performed some content analysis on these free text responses and actually found they seem to fall roughly into three themes. So one of which was the fact that consultants were frequently talking about the fact that actually there wasn't a local bed available for the young person. So numerous times they commented that actually this was the closest unit, but their closest unit was more than 50 miles away from home anyway. And some commented about having previously had a local unit, but this having been closed. In some cases, they talked about how the need of the young person was escalating so rapidly that there wasn't any time to consider more local admission. And for other times, there were parent or patient preferences which were expressed, which clinicians were trying to meet. Next slide, please. One of the other key findings from our study was actually how long and where people are waiting for these admissions. So we asked the consultants to be able to identify for us how long a young person was waiting and where, if they were able to identify that. And what we could see from our findings was that very frequently the young people are waiting within acute hospitals. So as shown from the table at the top of this slide, you can see that 40% of young people are waiting on pediatric wards. They're also quite frequently waiting in adult medical wards, emergency departments, and also on what is known as a Section 136 suite, which can be a place of safety within mental health, usually within mental health hospital sites. Also, nearly a third of these young people are waiting at home. And when asked how many days, as you can see as well, that over 40% of these young people are waiting for 7 days or more for their admission bed. And the highest amount of days that we were able to offer on the survey was 10 or more. But actually, from conducting interviews with clinicians, we know that for some of these young people, actually the number of days they were waiting was significantly more than 10 days. Next slide, please. When looking at our 6-month questionnaires, we were able to calculate that on average, for the young people for whom we had a discharge date, the average length of stay was 75 days, which, comparing to NHS England averages at the time and other published data, this is around 2 weeks longer than the average length of stay at that point in time. Around a fifth of the young people within our sample were still in hospital at 6 months. And also, we wanted to know about the journeys of these young people, so we asked about transfers to other hospitals. And we found that very few young people actually transfer during their admission, so about 19% of these people. And of those, around 27% of those actually moved to another general adolescent unit during their stay that is more than 50 miles from home, and therefore experiencing 2 far away from home admissions within the same period of hospital care. And only 42% of that 19%, so a very small number, are actually transferring to a general adolescent unit within their commissioning region. And as shown here, some patients are then moving on within the care system, within the mental health care system, to perhaps more restrictive units such as PICU or low secure. Next slide, please. We also asked the consultants about delays to discharge and found that they were indicating that actually discharges were delayed in over a third of these admissions. And when asked why this was happening, the most common responses were about the distance. So distance was clearly limiting in reach from local CAMHS in around 18% of these cases. And there was also difficulty in around the same number of cases in organising local social care support due to the distance again. And this was another one of the questions where we provided the ability to give free text responses. And again, we found that there seemed to be roughly 2 themes. One was that actually social circumstances were often a key delay to people's discharge. And the other tended to be around certain aspects of the patient's presentation. For example, some young people finding it particularly difficult in the run-up to discharge, and how this, if combined with difficulties in organising their discharge, could then lead to a patient's discharge being delayed. Next slide, please. So what are we wanting to conclude from this? So one key finding was actually that although there are a number of articles and policies around how we should end out-of-area admissions or admissions to adult wards, these very much still do form part of the mental health offer that we have here in England at this time. And with the movement towards fewer beds within mental health services, it's likely that at distance admissions are going to continue to be part of the offer that we have. Risk is a really key driver of these admissions. It's not that people are necessarily being admitted inappropriately, but actually these are young people who are presenting with really high risk, and their admissions are felt to be emergencies, and frequently under the Mental Health Act. And suicide risk seems to be a particularly strong driver of these admissions. That we within mental health services are using significant numbers of acute hospital bed days waiting for beds within mental health services. And we need to think about how we can manage that alongside our acute health colleagues. And that actually these admissions do have a longer length of stay than NHS England averages, and what are the implications of that in terms of costs, but also the implications for the young people and their families and all of the professionals working with them. And there is no getting away from the fact that the distance is leading to delays in discharge in a significant number of these young people's cases. Next slide, please. And in terms of thinking about, so what does that mean for clinical implications? Well, one of the key things that we're finding is that actually we're needing to move towards commissioning, which is based upon this real world data and understanding the needs of the young people in different areas of England. During the period of time that our study was conducted, there was the establishment of a number of the provider collaboratives, which have now taken over the commissioning of these services. And from talking to leaders of these provider collaboratives, it's hoped that through improved data collection and understanding of the local service needs, that this will be able to make a significant difference to the care journeys of the young people within the regions of England. For those working in the community, this highlights the importance of managing these really high-risk people and whether there are ways that we can identify escalating risk and manage it before these young people are reaching these emergency situations. For us to think about how do we collaborate with particularly our paediatric colleagues whilst young people are awaiting admission in order to be able to manage that often very difficult and fraught time in a young person's admission. And also to improve the links between community and inpatient in order to try to prevent delays both to admissions but also to discharges to improve patient flow. Next slide, please. And for inpatient colleagues, one of the things that we were highlighted was actually these faraway admissions are having significant impact on the families in terms of longer admissions, and they are definitely providing additional strain on families. So thinking about how we can support those to try to keep these admissions as short as possible. But also consideration of how do we try to standardize the unit skill set so that for every person in the country that they are not affected by the fact that some units do not offer specialist services such as nasogastric feeding or clozapine induction. And also, again, from the other side, improving the inpatient to community links to try to prevent discharge delays. Next slide, please. So in terms of next steps, as I've highlighted here, these webinar forms one of the outputs of this studies. We've also publishing our findings, and we'll talk about that. And we're also providing some guidance for units based upon the findings of this study, in the hope that this will help people when they receive a young person who is being admitted far away from home. Next slide, please. Thank you to all of the Far Away from Home study team. As you can see, this was an effort with a large number of people involved who worked brilliantly together. Next slide, please. Thank you very much for listening.
Thank you so much, Jo. A really clear presentation and an excellent study that you led on behalf of the team. Also just wanted to say a huge thank you to those of you in the audience who participate in CAPS and provided us with information through doing your monthly e-cards returning to CAPS and then completing questionnaires, both baseline and follow-up, that provide this very rich data set. In the time available, Jo has presented some of the main sort of headlines and highlights, but those of you who might be interested, the full paper with all the details has been published in BMJ Mental Health. It's an open access paper, which means it's freely available. So if you go onto the BMJ Mental Health website and just put in Far Away from Home, it will come up. I know a number of you have joined the webinar during Joe's presentation, so a very warm welcome to you. What we'll be doing is we'll be hearing from all three of our speakers, and then we have time for questions and answers at the end. You can pop into the Q&A box any questions that you have. If we have time, we'll try and cover as many of them as possible, but otherwise the speakers may be able to provide responses, typed responses for you. So we already have one in the box actually from Sulbu asking about whether we have data for young people who went to specialist eating disorders units or eating disorders. We don't in terms of this study. The focus was very much around general adolescent unit referrals and admissions, because for eating disorder, specialist eating disorder units, they tend to be regional. There are fewer available nationally, which means by definition many more young people will be far from home or out of area. But these are the sorts of data that national NHS England do capture, but not with the same level of richness as we've been able to share with you today in terms of who the young people are, what happens to them, and how they get on in terms of their outcomes. So I'm going to now move on to our second speaker, Dr. James Rowe. Jim is a research fellow in ARC East Midlands and the University of Nottingham.
So good afternoon, my name's Jim. I will be talking to you about the interviews that we carried out. So this is focusing on far away from home experiences. So next slide, please. So as Joe mentioned, the programme of work involved a number of different elements. So I'm going to be drawing on what we called study 2A and 2B. So if we go to the next slide, please. So what this involved was on the back of the surveillance study, we invited clinicians who provided us with information for the surveillance study to take part in an interview. So as part of that, we managed to get a really good geographical spread of both community and inpatient clinicians who had experiences of supporting young people who had admissions far away from home. And then what we also did as part of study 2B, around the 5 different ARC sites. So as I said before, that was East Midlands, West Midlands, Greater Manchester, Oxford and Thames Valley, and the East of England. We carried out interviews with a number of young people, parents and clinicians at those local sites. So next slide, please. So in terms of who we managed to interview, so we, across all the different ARC sites, we managed to interview 28 young people. And I suppose reflecting the data that Joe presented from the surveillance study, most of these young people were female, so 20 out of the 28 were female, and the majority of a white ethnicity. The average age was just under 16 at the time of taking part in the interview. And just to point out, we interviewed young people who had experience of an admission more than 50 miles away from home, but then we also did some interviews with some young people who had an experience of an admission near home, just to sort of see that either differences in their experiences or things that were the same as well. And I suppose similarly to what Joe mentioned in terms of young people who were previously known to CAMHS. So 10 of the young people who we interviewed had a previous admission, and the majority at the time of the interview were also living with one or more parents. We also interviewed 19 parents or carers. Again, these were mostly female and of white ethnicity. And again, we interviewed some parents who their child had been admitted far away from home and some who were admitted near home. So 11 who were at distance and 8 near home. And the majority of these were the biological parents of the young person. We also interviewed in total 51 healthcare professionals. So there was 19 who were community-based child and adolescent psychiatrists, 17 who were inpatient-based consultant child and adolescent psychiatrists, and then there was a range of other professional roles, and this involved It included mental health commissioners, also nursing leads, team managers. So next slide, please. So from the interviews, the themes that came up could roughly be split into 3 main areas. So things that happened in the pre-admission process and the actual admission process itself, experiences during the actual admission, and then things that can be categorised in terms of, I suppose, the discharge and sort of returning home phase. So from the pre-admission and the admission process experience, quite a lot of the young people and parents explained that they were often informed about the decision making process, but didn't actually feel actively involved in those decisions. So they felt that they had minimal involvement, minimal influence over the decision making process. And this was something that was also confirmed by the healthcare professionals that we interviewed, that clinicians were able to provide updates, but there wasn't any real room for them to get involved or actually influence where the young person was going. However, what was also expressed by both young people and parents is that although that they didn't feel involved, actually being provided with those regular updates and having, if they were provided with regular updates and if they were communicated with on a regular basis, that was valued by the young people and parents for keeping them in the loop. And then related to that, young people and parents, carers and healthcare professionals all reported that there was just a lack of options and limited alternatives to these at-distance admissions. Young people, in fact, even expressed that at times they felt a certain pressure to accept a bed that was offered to them. Many even described how they said that they were given the options of either an informal admission, but then that had the caveat that if they refused an informal admission, that would result in an assessment for an admission under the Mental Health Act. So some felt that they had to agree to a voluntary admission in order to demonstrate their eagerness to sort of get help and sort of get better. Clinicians themselves sort of, again, as I said, that they expressed that there was just a distinct lack of choice, a lack of sort of alternate options. And they were fully aware of how, when they had to explain this to parents and young people, that they found these conversations upsetting. Psychiatrists, a number of psychiatrists expressed they felt powerless over the situation. And for many of them, they just felt that the priority of whether or not a young person required an admission took precedence over the actual location of where the young person was going. Conversely, with some near-home admission experiences, when these were more likely to be routinely planned, young people expressed that they felt that they were given more of a choice of an informal decision, and they expressed that they felt a bit more engaged with these discussions. So next slide, please. Yeah, and so for many parents and carers, the weeks leading up to these admissions, they sort of expressed that they found it was very stressful, involving a period of sort of escalating risk. So parents often described basically taking the first bed that was made available through them through sort of pure desperation, with many reporting sort of a relief that a bed had become available. Often sort of expressing they were relieved to finally have somewhere that their child was somewhere safe. Again, clinicians, healthcare professionals reported that parents often were relieved that their young person their child was being able to go somewhere to a safe place and receive help, because they were unable to manage the situation at home. Next slide, please. So moving on to the experiences during the admission itself, or sort of slightly crossing over with the actual admission process. One of the key things that sort of came out quite a number of times was that because when a bed became available, young people often reported they were given very little notice that a bed was available. Some were actually told just the day before, even on the day itself. So they expressed that they had often limited time to sort of mentally prepare themselves for these admissions, particularly with the distances involved. And the young people and the parents highlighted concerns they had about, I suppose, inconsistent availability about information about a unit, with young people and parents recalling having to carry out their own research, sort of trying to find out information online about the unit that they were going to. Many reported feeling scared and anxious at that time. And if they couldn't find much information out about the unit that they were going to, this sort of exacerbated the situation. Whereas conversely, if they were able to find information out about a unit, it made things a little bit easier. So one parent who was sent a digital booklet about the unit found it helpful and found visual images of the unit to be a bit more reassuring about where their child was going. Furthermore, for some near-home young people, some young people had near-home experiences because they may have known about the unit that was in their local area, and some actually knew of people that had been to the unit before, so they had that sort of reassurance, or they had sort of people that they knew giving them information about what that was like. So that sort of helped in the preparation. And then once a young person was admitted, one of the issues that was coming up was around keeping in touch with home. So many young people expressed how they found being on the unit as an unreal environment. And as part of that, one of the sort of frustrations was that difficulty in terms of maintaining contact, so feeling isolated, unable to see friends. Parents and carers also expressed similar difficulties keeping in touch with their child, and sort of felt that impacted on their own health. The young people themselves sort of mentioned that at times the distance, being away from their family, they felt that was slightly detrimental to their own recovery. Some were sort of saying that they were able to maintain contacts using stuff like FaceTime, but this was viewed much less favourably than the option of having inpatient visits. In addition, the varying rules that exist between different inpatient units meant that some young people had limited access to their mobile phones, which compounded their concerns about maintaining contact. They also expressed concern having limited contact with their own local clinicians from being far away from home, which later impacted on sort of the discharge process that I'll come to in a moment. So next slide, please. And then one of the other main sort of issues that kept cropping up throughout the interviews was the burden and the impact of visiting. The distances involved with some of these admissions were identified as incredibly difficult. For young people themselves, they often felt incredibly guilty about the travel costs that were incurred for their parents to come and visit them. They expressed that the staff on many of these units tried to be flexible and sort of make accommodation for this. So, for instance, allowing parents who have travelled far to sort of stay longer. But quite frequently, the young people who were the furthest from home felt isolated when they were seeing other young people on the unit having frequent visitors. The healthcare professionals confirmed and sort of agreed that they were aware of the struggle that this was posing on sort of families in terms of both financial, but then also time commitments to visit their child. One clinician recalled that a parent was only able to visit once or twice over a 6-month period. Young people, a young person also explained that they just didn't get as many visits as they would have liked, just because of the logistics around it. Families also expressed additional challenges around supporting or caring for the other siblings of the child, and also for securing leave from work. I suppose and then healthcare professionals also strongly advocated for sort of trying to break down some of the barriers around visiting children far away from home, in terms of the need for clear information about what financial or other support was available. This seemed to be quite mixed across the country, or that it wasn't, how to put it, it wasn't readily available in terms of what practical support was available, and often parents had to try and seek that out themselves in sort of trying to find if there was anything available. From a clinician's perspective, they also expressed how difficult it was in terms of, I suppose, involving the family in family therapy, or being involved in in-person ward rounds because of the distances involved. Despite these, there were some positive impacts that were identified by both young people, parents and clinicians associated with these far away from home admissions. Young people expressed how there was a reduced possibility of being recognised if they were on local leave. They also expressed how the distance often made it easier to avoid unhelpful or toxic relationships, as they described it. So they were less likely to engage in risky or harmful behaviour because they were away from their usual sort of social circle. Healthcare professionals sort of agreed. They sort of felt that if there were often issues in the local environment, or if family dynamics were posing part of a problem with the young person, then the distance sort of placed there could actually offer a bit of space for the young person, to give them time to regroup or reflect. And some young people actually found the distance empowering and sort of allowed them a bit more independence. For some parents, they sort of identified that it too gave them a little bit of respite, feeling a bit of relief from the challenge of trying to keep their child safe at home. Next slide, please. So in terms of continuity of care, so thinking about home leave and discharge planning, for the majority of the young people that we interviewed, they were actually still within a unit at the time of that we carried out the interview. So a large majority of these data was drawn from parents and also from clinicians. But I suppose related to what Joe was saying about the issues of far away from the problem with the far away from home admissions on discharge planning. The being placed far away from home offered limited options for home leave, with often young people feeling daunted about the idea of being discharged without having these periods of home leave. Others expressed that they had concerns that if they were to have home leave, there was the worry that if they struggled at home, then it might be even more difficult to get back to the uni because of the distances involved. And this was again agreed by healthcare professionals, highlighting the issues around arranging these leave. In terms of discharge planning and returning home, one of the main issues that was identified was around access to school and college work, that young people just could not easily attend their usual school. But then there was also issues around poor communications between agencies, which created these uncertainties and prolonged discharge. Next slide, please. So what does this all sort of, all these experiences sort of tell us? Basically that at distance admissions can exacerbate the distress and uncertainty for young people. The lack of information provision and those feelings of powerlessness is quite a big issue. The negative impacts that these far away from home admissions had on the young people and the parents were mitigated to a certain extent by good practice at some units, but as sort of mentioned, this seemed to be quite sporadic and different across England. There were some clear beneficial aspects associated with some of these far away from home admissions. I suppose in an ideal world, matching appropriately the right service for the young person's needs, as well as access to particular interventions, would be the sort of the way forward. But importantly, more active involvement of the young person and family members in the admission process would be welcomed. And next slide, please. Oh, next slide, please. And then, yeah, in terms of clinical implications, yeah, as I said, so improved clarity during that admission process is needed. A more co-produced information about units needs to be more accessible, having that easily accessible information that's co-produced, and also the additional burden of the financial costs in particular sort of leans towards the need for a national policy of support provision and sort of wider funding available for parents. Next slide, please. So just quickly in terms of the next step. So one of the things I mentioned was around the lack of information that's readily available about units or the variation across the country. So what we're doing at the moment is working with some young people and parents to try and co-produce a standardised set of information that inpatient units need to make publicly available. And that's part of the Knowing Where You're Going project. Next slide, please. Thank you very much.
Thank you so much, Jim, and well done on overcoming those early tech glitches. A very clear and succinct presentation. And again, as I was mentioning after Joe's presentation and study, if you're interested in further details around the greater depth and detail of these qualitative interviews, the paper reporting this has very recently been accepted also in BMJ Mental Health and will hopefully appear there in press soon. Again, open access and freely available. And at the end of the webinar, we will be sharing with you the links to our 2 animations, which give a very brief summary and overview of the main quantitative, the surveillance study, and also the qualitative study. So the facts and the figures and the hows and the whys and the whats. So I'm going to go on now to introduce our third and final speaker, Dr. Anne-Marie Byrne, who's a senior research associate in ARC East of England and the University of Cambridge. And one of our main aims in doing the Far Away From Home programme was also to look at the issue that sometimes crops up of under 18s who are then admitted to adult mental health wards, which is something that is really for many years has been felt to be and thought of as a never event, but still does continue to happen. Fortunately is a much more rare event than it used to be, as indicated in the figures from Joe, but still the learning from that is very important, so that in situations where this does crop up, that as clinicians working either within CAMHS services or indeed adult mental health services, that we are better aware and informed to make these experiences as manageable as possible and the stay as short as they can be. So I'm going to now hand over to Anne-Marie. Thank you.
Thank you, and good afternoon, everyone. So I'm going to be talking about the qualitative work that we've done to explore the impact of young people's admissions to adult mental health wards. Next slide, please. I'm going to start off by giving some context and background to the study. Next slide. I think a lot of this has been covered already, but basically some young people will need a hospital admission because they're at high risk and may have complex mental health needs. But there is regional variation in terms of adolescent inpatient provision, and this can lead to difficulties in locating an adolescent bed. And it can result in a young person being admitted to an adult mental health facility. Next slide. This has raised some significant concerns, especially in the media, about the rise of young people being admitted to adult wards. And there's very little research in this area. Next slide. So to address this gap in the research, we've conducted this study. Now, national policy actually recommends that under 18s be admitted to a ward appropriate to their age. And there's very little research in how this impacts young people and families. There was a report by the Children's Commissioner for England in 2007, which did highlight some of the negative impacts of these admissions. And young people said there was nothing to do, no one to talk to, and there was a lack of safety, security, and therapeutic care whilst they were on the ward. There's been a couple of surveys as well with clinical teams. There was a survey with UK psychiatrists, which reported that young people were still being admitted to adult wards, and some of them were as young as 12 years of age. And there were adverse experiences for these young people. For example, witnessing self-harm and suicide attempts on the ward. And in another survey with psychiatry staff who had experience of caring for young people in adult wards, they said they felt ill-equipped to deal with the admission because they lacked specific training. Next slide, please. So the aims of this study were to explore the views and experiences of young people, parents and professionals regarding the treatment and care of under 18-year-olds in adult mental health wards, and also to identify ways to improve services. So we conducted one-to-one in-depth interviews with young people and parents with experience of an adult ward admission and professionals in adult mental health services who had experience of caring for an under 18-year-old. Next slide. So in total, we recruited 29 participants, and 21 of these were professionals from adult mental health services. And we had representation from every NHS region in England, and they included adult consultant psychiatrists, nurses, ward managers, and service commissioners. We also recruited 4 parents and 4 young people. We acknowledge that this is a small sample size, but this was a very difficult population to recruit. And we also had some difficulties because we were recruiting in the pandemic, there were ward closures and staff illness. Next slide, please. So now I'm going to talk through some of the findings. Next slide. So our analysis generated 4 main themes, and these themes had sub-themes as well. And I'm going to talk through each of these in the following slides in a bit more detail. I'm also going to give you some of the quotes from our participants which help to illustrate these themes. Next slide. So professionals described admissions as a last resort and usually involve young people who are at high risk of harm or suicide and have usually been detained under Section 136 of the Mental Health Act. Young people and parents also provided similar narratives. They spoke about the escalating risk leading up to their admission and that there were just no adolescent beds available for them. Here is a, please go back to that. I was just going to read that out. Yeah. Here's a quote from one of our parents. She took a big overdose and disappeared, and we had police out and drones and things looking for her. And she was then taken to hospital. Then there were big discussions about where she would go. They said there's no adolescent beds. Next slide, please. So also what came up in the interviews is professionals talked about the challenges of involving families in the referral process. They said it was often really difficult to involve young people in the decision-making because they often lack capacity at this point. And also parents are often very distressed and struggling to cope. And they said that parents were often very relieved when a bed became available, even an adolescent bed, because they saw it as a place of safety for their child. But young people told us, spoke of a lack of agency in the decision to admit them to an adult ward. And here's a quote from one of the young people. They literally said, the ambulance is going to be here in about half an hour to come pick you up. You're going to adult ward. And I was like pleading not to go. I really didn't want to go, but I had to. Professionals did say, though, that admissions were intended to be a short-term safety measure, and therefore they saw their role as just to keep the young person safe, rather than providing any therapeutic input. Parents and young people had also been told that it would be for a short time, but then they reported that there were prolonged stays. For example, this parent said, I just kept thinking it would be a couple of days before a CAMHS bed would be available, but days turned into a week turned into 2 to 3 weeks. Next slide, please. This theme is about how appropriate adult wards are for young people. Overall, professionals felt that adult wards were inappropriate for young people, and they based their concerns around patient comfort, risk, and safeguarding. They said that young people on the ward often felt frightened and unsafe being around the adult patients, and these were adult patients who were severely unwell and often had very unpredictable behaviour, which could be distressing for young people. Professionals were also concerned about the risk and vulnerability, especially of under 16-year-olds, and being around adult patients and perhaps even forming inappropriate relationships. They spoke about their concerns about young people learning maladaptive behaviours from older patients, including self-harm. And they said that sometimes young people witness traumatic events on the ward, such as suicide attempts. Here's a quote from one of the professionals. I think they found it quite distressing. I think initially very scared of the environment, not wanting to come out of the bedroom, not wanting to spend time on the ward, isolating themselves in that area. I can imagine if I was that age and being with a group of adults with mental health issues, that must be terrifying. And one of our young people had witnessed a suicide attempt on the ward, and they said it affected me in so many different ways I can't even explain. Like it brought back so much of my flashbacks, so much of my PTSD, and it just made me 10 times worse. Next slide, please. Also, in terms of appropriateness of adult wards, there was a lack of education provision and age-appropriate activities, which meant that young people often felt bored and isolated on the wards. There was no structure to their day, and they said this was very different from an adolescent ward, which they'd experienced, which provided them with activities, things to do, and schooling. This is a young person talking about when she was on the adult ward. When I first came there was nothing. There was no groups, like obviously no school, and like nothing was happening in the day. And so I kept myself entertained in my room. However, lots of professionals did say that an adult ward may be clinically or socially appropriate for some young people. And they suggested it could be young people who are approaching the age of 18. They could be independent, even have lived independently, and mature for their age. They also said there are some young people who present with aggressive behaviour, and it may be better that they are on an adult ward because they may pose a risk to young people if they're placed on an adolescent ward. So this professional said, I think, again, it has to be factored in around risk and the maturity of what their need is. Next slide, please. So this theme is about the impact of these admissions on services and provision of care. So professionals told us that there are no protocols for them to manage and treat young people. And this could create all sorts of problems and difficulties for the staff who didn't have any specialised knowledge or experience in working with adolescents. As one professional said, it was a very different nursing style, which I think we don't necessarily have experience or training in. But some professionals said perhaps the approach in adult mental health services could be more beneficial for some young people. They said it's less paternalistic, they're less risk averse, and they're more focused on empowering individuals in their recovery. However, parents and young people reported there was a lack of treatment and therapy during their time on the ward. This young person said, adult services isn't as good as CAMHS services. In children's services, you get psychology input and the doctor's input and stuff like that. Whereas if you're on an adult ward, you're basically just left to sort yourself out and then get discharged. Next slide, please. One of the things that happens when a young person is placed on an adult ward is they're placed on one-to-one observations, and this can mean somebody sitting in the room with them. And as far as possible, they're kept away from adult patients. But these high levels of observation were seen as intrusive by all of our participants. For example, patients are even monitored when they're in the bathroom. And also being kept in a segregated part of the ward can feel very isolating for young people. As this professional said, the patient's family felt she was imprisoned in our unit. Professionals came up with a number of barriers and facilitators of collaborative working, which could also impact the provision of care for young people. They pointed out that sometimes it's very difficult to get timely information and advice from CAMHS clinicians about the treatment of young people on their ward. They also pointed out there's very different approaches between adult services and adolescent services in terms of their philosophy and their attitudes towards patient risk and management. And this can sometimes lead to potential disagreements in terms of treatment of the young person. However, they did give examples of positive and effective working relationships. For example, when community teams visit the young person on the adult ward, this facilitates continuity of care, so the young person is familiar with that team when they're discharged. Here is a quote from the professional. "It would just be nice to do a bit more joined up working, but that requires resource, and we don't have that resource." Next slide, please. So this is the final thing. These are recommendations for service provision and policy. Professionals held very strong views that they felt it was important to have an integrated pathway where both CAMHS and adult teams were involved in the decisions regarding treatment plans and discharge. They said the shared notes system would help facilitate information sharing between services, because sometimes these notes weren't always passed across. They also suggested that CAMHS and adult psychiatrists could meet weekly for supervision and guidance. And parents expressed the need for greater coordination between mental health services and social care. And here is a quote from one of the parents talking about her daughter's experience. "And we're caught up in the middle of all of this, these arguments between health and social care. There's no joined up thinking between the two. It's almost like it's a triangle and she's caught in the middle between health and social care. There's nothing joined up and there's no one fighting on her behalf." Next slide, please. There was a very strongly held view across all of our participants that there should be an increase in community provision. They felt that there was the potential to reduce adult ward admissions through earlier community-based support, and better resource community teams could address problems early on and prevent escalation and facilitate timely access to services. They also emphasised the importance of providing out-of-hours support for young people, because many young people go into crisis overnight, so there needs to be that kind of support at those out of hours. They also said that this also needs the increase of retention and recruitment of professionals, as well as investment in staff training. Here's a mental health professional's quote. "We should not be using the inpatient service as the default, which sadly it becomes for a lot of young people because they've not had the right care and support in the community. And that's where the investment's got to be." Next slide. They also provided some recommendations for policy. Many people said that further research is needed because it would help to determine the appropriateness of admissions for specific young individuals. Also, admissions should be made on a case-by-case basis and should factor in things about clinical and social need of the young person. Clinicians should have some flexibility and discretion in deciding whether a young person needs a one-to-one observation on the ward. And also this was an important thing that people felt strongly about, which was providing support for families with the transition from adolescent to adult wards. And this is a quote from the young person, and this was her suggestion. "I think they need to help with the transition to adult services. Like I say, I've made quite a lot of friends and they're around my age and their transition to adult services has been really bad. I think that there's a big age gap in the adult wards, and there needs to be a bridge between that. I feel like there should be a unit for later teens, early 20s, because you're still developing at that age. Yes, you're classed as an adult, but you're still getting the independence. Next slide, please. Next slide, please. Thank you. So just to conclude, our findings from these interviews align with current policy that emphasises the importance of admitting young people to age-appropriate inpatient wards. Adult ward staff need appropriate support, training and protocols for the management of adolescents in their ward. And also professional bodies may need to consider how current provision of pre and post-registration training could be improved. And finally, investing in community and crisis care services could help prevent hospital admissions and reduce demand for inpatient resources. Next slide, please. Thank you all for listening. I hope you found that interesting.
Thank you so much, Anne-Marie. A really clear presentation, shining a light on events that unfortunately still do happen, and it's really important that we're able to understand them as well as we can, and have best learning around that, so that we can make this as optimal experience when these situations do occur. We have a few minutes left before we finish, and just before we go on to some questions and answers and discussion, I just want to take the opportunity, firstly, to thank all three speakers for very clear, succinct and detailed presentations in terms of the findings that have been emerging from the Far Away from Home project. Also, big thank you to Kieran and Michelle from ARC East Midlands for all your help and support with planning and organising this event and webinar. Has been hugely appreciated. And of course, especially all the young people, parents and carers, and clinicians and healthcare professionals who've taken part, and our study advisory groups, young people, parents and carers and professionals who've been working alongside us over the last 4 years to make sure that we ask the most important and the right questions and answer them as best we can. Thank you so much to all of you. Throughout the webinar, you've been posting questions, and Joe and I have been trying to answer as many of them as we can as part of the Q&A chat, particularly the more factual ones. We still have a few more minutes if you want to add in any more questions, but I'm going to just read. It's actually a comment rather than a question. I think particularly relating to your talk, Jim. So you may wish to respond to this one. So it's from Esther, and it's a comment about what you were saying, Jim, about people not getting enough notice about where the bed is and where and when they're going. As a crisis team consultant, sometimes it can be troublesome to inform families of a bed before it's definitely agreed, as sometimes a closer bed becomes available. Or sometimes tabletop discussions yield the unit to decline the patient. So it's an ever changing scenario. Then when the bed is agreed, there is pressure. The pressure is on for transfer as soon as possible, as staying longer in the paediatric ward to get used to the news tends to feel undesirable. So that's the really highlighting on a moment-to-moment situation, just how rapidly changing things are, but how difficult it is all round. But Jim, I wondered if you'd like to comment, and then perhaps Joe or Anne-Marie, if you wanted to add anything, please do.
Yeah, and that's something that was mentioned by the clinicians as well. I think it's, I suppose, from the young person's and the family's perspective, yeah, it's just their experiences of being told at the last minute. I'm aware that from a clinician's perspective, sometimes your hands are tied and things like that in terms of what you can and can't sort of actually do in the moment. But then I suppose in addition to that, just to emphasise what some of the young people and the parents said, it's just that being informed about that, what's the word, being transparent, just being clear with the young people, sort of just having that constant communication, even if there is no information, just they sort of welcome those regular updates of we are still looking, there's nothing yet and stuff like that. So it's just having that transparency and that continual conversations, even if there is no update, which is better than nothing, I suppose.
Thank you so much, Jim. This possibly time-wise, maybe our final question, Joe. I think you've started to type, but you might just you or Jim or Anne-Marie might want to say a little bit more. So it's a question about whether the team have any intentions to have a deeper dive into the issues leading to admission or other issues raised. I don't know, an opportunity maybe to say a little bit more about the knowing where you are going work and the additional policy-related funding that the team have secured, because obviously it's very important here that we've some answers have emerged, but of course the big question is, well, what next? What impact might this have?
Yeah, absolutely. I can come in on that. So we're definitely wanting to extend from some of the findings of this study. So as Kapil mentioned, one piece of work that we're doing is looking at the information that's available online, particularly at that quite difficult transition point that the comment from Esther really highlighted, that the young person and parent might get told the name of the unit and then very quickly move towards it. And how can we try to give easily accessible and understandable information about a unit that somebody can easily access when they just Google the unit? Because at the moment, what we're finding is that there is huge variation between units in terms of what can be accessed quickly. So that is one of the things that we're leading on from this. We are also doing a deeper dive into the data again, in terms of thinking about whether there are some inequalities in some of these experiences that people are having, and thinking about whether these admissions have a particularly negative or positive effect on certain patient groups. And we're looking at analysing it from that point of view, and then writing something from that point of view as well.
Thank you, Joe. Just a comment from Amit around, policy direction currently is around trying to reduce the number of beds, which will create existing pressure. So certainly that's very much what we're hearing, certainly in relation to England. And if anything, what that will mean going forward is that even a greater proportion than now of admissions are going to be far away from home, out of area or at distance. So the learning and insights from this study becomes even more relevant. In fact, particularly the work that Jim and Anne-Marie have shared with you today, in terms of us being better informed and better aware of the potential pitfalls, but also what might be possible ways around that to make these admission experiences as appropriate and optimal as possible to achieve the best possible outcomes. Anne-Marie or Jim, I don't know if you wanted to add anything to that.
Well, I think the comment was about at the end of my presentation that it aligns with policy, and what I meant by that was trying to make sure that young people are put on age-appropriate wards, but of course it is still continuing to happen. So that's what I meant, but not necessarily other policies.
Absolutely, and actually both coexist, don't they? In terms of there'll be local policies about where is the most appropriate bed within any given NHS trust, but then of course national policies in terms of commissioning, and then the directives to provider collaboratives in terms of what budget is available, and at a regional level what the provision might look like. I'm afraid we're out of time. It's been an absolutely brilliant webinar. I hope you agree with me. We've had three fantastic speakers presenting a wealth of data. Of course, we have much more to share. We've signposted you to two of our published papers so far. The adult admission paper that Anne-Marie's presented is currently under review with the journal, and hopefully that will be out there in the public domain with yourselves soon. But as I was mentioning right at the outset, we're also really pleased to have two brief animations that they're only 4 or 5 minutes long in total, that we've developed in partnership with ARC East Midlands, which we're really proud to launch today. I think, Kieran, you might be coming in with with both a QR code that you can take a picture of, which will take you straight to the animation, and these two videos will be hosted on YouTube. It's a very brief summary of what we've been doing, so please do do click on that and have a look and share that widely. As a follow-on from today's event, we're going to be in touch with all of you who have registered, and we'll send you in an email details of this, as well as a certificate of attendance. But I don't want to keep people away from their lunch if you've delayed that, or chance to have a quick drink before going on to your afternoon commitments. So thank you so much everyone for joining us today and for your interest in this work, and please don't hesitate to keep in touch with us if you have any other questions or want to know more about the study. We have a Twitter account at Faraway Jim, I think it's at Faraway Study, and email is faraway@nottingham.ac.uk. So thank you very much, and we hope to see you again soon.